as part of the topic which we started last time, aortic aneurysm, I told that one way is to deal the patient in an emergency with a ruptured one, and the other one is either elective in the form of open or in the form of endovascular. Okay, so today I will just give you some insight about like what are the general consideration in endovascular procedures. Okay, so like how many of you have done any endovascular procedure? Yes, anyone please? Endovascular procedures. Yes, anyone would like to say something or no? I'm sorry? Yes, what are different endovascular procedure we face? Like one of them is like limb revascularization, okay? The revascularization or some things like that. AV fistulas, okay? Are AV fistulas endovascular procedure at some time or no? Actually, AV fistula creation is open procedure, okay? But there is a something which is, you will be surprised, even few years ago, around 7-8 years, for the first time I heard this terminology, interventional nephrology. It was something new for me. Before I find one of my old class fellow, my buddy, who did fellowship interventional nephrology. So actually AV fistulas, their like creation is being done by the urologist usually or vascular surgeon, and their maintenance is sometimes done by a like interventional nephrologist. I will not say new because I don't know when this specialty was discovered. Okay, so anyways, now there is a interventional nephrology as well. Okay, so this is one thing. Then neurovascular problems. Any other example of endovascular procedures? You know, if listen one thing, I'm not giving a lecture. If you will be interacting, then my effort is fruitful. If you are silent and not speaking anything, say something, maybe say something wrong. That's how you will learn.
Endovascular aneurysm.
Yeah. Yes.
Aneurysm filing.
Aneurysm. Okay. Or
minor valve clipping.
Very good. Valvular.
Embolectomy.
Valvular, mitral or aortic. These are also endovascular. Then actually it's angiography, as I write. Angiography is also angiography or angioplasty is also angiography, may be coronary, maybe of any area. Okay, this will be also an endovascular procedure. Then there are actually pediatric procedures like PDA, device closure. Okay, there are, as I told you, mitral valve clipping. These are all endovascular procedures. So there is another procedure which is called as TAVI or TAVR or TAVI. So like this is transcutaneous aortic valve repair, aortic valve intervention. It is transcutaneous or yes, it is I'm just myself confused. TAVI is either transcutaneous or transvascular, I forgot, but it is aortic valve replacement or intervention. Okay, so
The transcutaneous aortic valve intervention.
yes, transcutaneous. Okay, so this is also an example. So what are basic principles? Actually, there may be operation theater with the angiography, okay? But usually they may be done in the cath lab, okay? Or this vascular interventional area, like interventional radiology. So what will be the concerns there? What will be the something different there? In addition to, of course, the patient related concerns will be there anywhere. Okay, but what will be the area related? So it will be NORA, non-operating room anesthesia. Okay, or you can say ambulatory, because it will not be your operation theater. It will be different. Maybe anesthesia machine will be there, maybe all the gadgets will be there, but it is you can say that unfamiliar area and limited manpower and limited things like that. This is one thing. Then it is usually a very cold place because of the machine and everything. Okay, then there is radiation, like radiation involvement. Okay, then the another problem is that at any time the surgical involvement will be there, conversion. Okay, so like apparently they are, for example, they are doing in local, but at any time may need to give GA, and patient is stable. At any time patient become unstable suddenly. So you have the area when you have put an endotracheal tube and you have prepared yourself everything, then you are relaxed. But in a scenarios where anything can happen suddenly, that makes it very tricky. Okay, so whether it is any this actually discussion is related to even any neurointerventional radiology, because for example, treatment of stroke, they are doing it. Even there are so many procedures which they may be done in that way. Okay, so one of them is the one which we discussed, this aortic aneurysm. Okay, so this is one of them, and we had already discussed about all the monitoring, and so the bottom line is that you have to optimize the patient. You have to prepare the patient as if you are doing open, and you are ready for any sequelae, because at any time aneurysm can rupture, and their excess is born, and they might need to open. So you have to be ready for anything like that. So you will be prepared for all monitoring. You will be prepared for all vasodilator and vasoconstrictors and everything which we discussed. Actually, you should be ready for it. Yes, to start with, you are doing only monitored anesthesia care. How will you define monitored anesthesia care? Yes, Shamail, what is monitored anesthesia care?
Sir, sorry, I have no idea.
Just try to answer. Just try to answer.
In which we are just monitoring the patient without any active participation or
Very good.
anesthetic use.
This is what is monitored anesthesia care. It is provision of the care provided by a trained anesthetist with or without giving actual any with or without giving any anesthesia. So monitored anesthesia care example, for example, very good example is cataract surgery. Even if you are not giving the local and you are sitting there and be ready for anything. Okay, so that is one of them. So you are giving monitored anesthesia care. Okay, then for example, if you are giving some sedation, so how can you classify sedation? Like one is conscious sedation. What is conscious sedation? Yes.
Propofol anesthesia.
Dr.
The
Humaira,
patient responder.
No, propofol anesthesia is not the answer for conscious sedation. What is conscious sedation?
The patient respond on the verbal commands.
Very good. Patient is responding to either verbal or little stimulus, like you are tapping, just by small tap, patient is responding. Okay, patient is quite calm, and we usually classify or grade the sedation or by Ramsay scale. Okay, have you heard of this Ramsay sedation scale?
Yes.
So you should be okay. So this is Ramsay sedation scale. Okay, patient is like relax, it is level 1. Okay, and then you can find about it. Okay, so usually you want it at around this level. Yes, Dr. Sadaf.
Is dissociative anesthesia an example of conscious sedation by ketamine?
Yes, but in it will be deep sedation. Okay, it will
Okay,
be. I was about to tell you that one is conscious
Yes,
sedation. Okay, actually, you know, if you ask me honestly speaking, dissociative, when the patient is dissociative, actually it is you are unable to communicate. So it is even not deep sedation actually, because in deep sedation patient is not responding to even painful stimulus, for example. Okay, or you can say that patient is responding to a lot of stimulus, but in dissociative anesthesia patient is not aware. Usually dissociative anesthesia, this ketamine is included in the medication which we are using for this procedure. The terminology is procedural sedation. Okay, because these procedures which we just chalk out, even it is vascular procedures. There are procedures in MRI. Okay, CT scan, this endoscopic procedures, like endoscopic procedures, like for example, this bronchoscopy, this colonoscopy. Okay, ERCP. Okay, and gastroscopy. So, like these are all sort of, you can say the terminology is procedural sedation. Okay, so actually, honestly, as a concept wise, patient is dissociated. It is not in the level of you cannot quantify it. Okay, so so this is actually a tricky statement. So you can say that it is sort of deep sedation. Okay.
Okay,
So
sir, thank you.
other medication which are here, as Dr. Humera was saying, propofol. So propofol can be doing nothing, or propofol may be causing full knockout anesthesia. Okay, so, patient is knocked off with propofol. It depends on the dose which you are giving. So propofol anesthesia, you cannot say it as a conscious sedation only. Okay, so propofol, midazolam. Okay, dexmedetomidine. What else? Remifentanil. Okay, fentanyl. As I told you, this one, you are saying ketamine. So what else can be used? Any other medication in before they used to have this chlorhydrin? You know what is that medication which is being used in the pediatric patient, chloral hydrate? I have never used it myself, but I have heard that they use this chloral hydrate to sedate the patient. Okay, so actually these are the questions which they can ask you with reference to Ramsay scale MCQs, and then different options, different medications, how they are using it, what are. So what will be the like indications we have? What will be the contraindications? Where you would not like to sedate the patient like that. What will be the contraindications?
If patient is not NPO,
Aspiration risk, okay? Like NPO is one, will be one of them. The patient cannot secure the maintain the airway, okay? Or patient has difficult airway. So it will be a relative contraindication. Like patient with the OSA, you give sedation and now you are not able to control the airway. So it is one of them. Then what else? Okay, what else, please? Think. If patient is not able to lie flat, okay, like it will be coming actually in the airway, okay, but patient is not able to lie flat, patient is not like cooperative. For that you need the cooperation, okay. So how will you do it if the patient is not cooperative? You cannot do this sort of thing, okay. And for example, any surgical thing they are expecting for example bleeding, okay. So of course in these procedures they always can occur, but if there is high risk, you will not do it under this sedation, okay. So then it will be
sir,
difficult
full
for you.
stomach pregnant female.
Yes, aspiration risk, okay.
Altered sensorium.
Yes, cooperative in uncooperative patient. Yes, anything else?
Why cannot we use this type of sedation in risk of bleeding?
Actually, when there will be sudden bleeding, what will happen?
The blood pressure will drop and
Like
tachycardia will
hemodynamic,
occur.
patient will have sudden hemodynamic collapse. So if you are expecting
Yes.
such thing like that, it is better to have proper control of the things. Okay. So it is like that. Actually, these things, there are so many ifs and buts and question marks, open-ended things. So have you heard of Sivonox? I forgot in the list of these
No.
medications. There is one thing is Antonox. Okay, and actually combination of sevoflurane with Antonox is Sivonox. Okay, this you will not find in the books, but it is a terminology. Then another is there is one terminology, neuroleptic anesthesia. I forgot it. I think it has opioids plus
Combination of fentanyl and
like
something else.
antipsychotics, psychotics,
Yes.
antipsychotics. Patient remain aware of his or her person, surrounding and condition, but without experiencing pain and anxiety. Okay, so they have done it with sevoflurane. If we are giving in slightly, what will be the we will do in detail inhalational anesthesia, low flow anesthesia, vaporizers, soda lime. We have to do it once someday, inshallah. But it will be depending on the MAC you are giving. Okay, there will be MAC like a dose dependent sequelae. There will be response to hypoxia, and hypercarbia will be blunted. Patient will not be able to respond like to the hypoxia and hypercarbia in the way it will be responding in otherwise. So with high back, even patient can go in apnea. Usually it requires more MAC. Okay. So we will discuss in detail about TIVA, TCI. You will find here target control infusion as well. So I will come back to what we were discussing, this endovascular aneurysm. So we have almost done the aspects which we had done before. You should be knowing about the type, size, and location. Okay, and coexisting disease. You will be optimizing the patient, like cardiac evaluation, need of echo, need of. We have done this in our previous discussion. We did it. Is it decision? Is it your decision? Is it your decision to have open or endovascular or the surgeon? It's not your decision. Okay, it's a surgeon's decision. They had some criteria which patient is more suitable for endovascular and which patient is more suitable for open. Okay, and usually they are not expecting you to they are not asking you about the decisions because the morbidity will be less if you are doing endovascular. Okay, so for your concern is to protect the spinal cord. Your concern is to protect the kidneys. Your concern is to maintain the hemodynamics during the clamping and after opening of the clamp, after unclamping. So this is actually your concern. As I told you about these things, I just discussed that there will be unfamiliar environment, radiation, cold environment. Okay, so you should have the sufficient lines, positioning, and another thing. Usually, you in other tables, you are able to have the head up or head down. In this table, these interventional radiology tables, they are not able to have head up, head down. Usually, they go up or down. Okay, so this is another thing you should be thinking. So rest of the things, actually, if you have not listened to our previous discussion, you can have a look on it. I did not go in details of the cardiac evaluation and the comorbidities, which because we have covered these topics in a separate. They will be using heparin. So if you are thinking about giving any regional anesthesia, you have to outweigh risk versus benefit. People are doing it. They can place it before to blunt the stress response, especially if it is open. Then it will be a big incision and you might need it. Okay, but usually it's it's a tricky decision. Not everyone will be doing epidurals in a patient which are receiving anticoagulants. Okay, so this is like complications like leak and arterial rupture, dissection, embolization, ischemia of kidneys, spinal cord, bowel. Okay, so these are actually surgical problems, these leaks and migration and infection. So we will prevent spinal cord ischemia by maintaining the blood pressure, trying to maintain have any bypass. They can have bypass, or we can use N-acetylcysteine as we discussed before, CSF removal and maintaining the CSF. You see, this is the spinal drainage of CS can be used to prevent or treat spinal cord ischemia. So things like that. So actually this is just a repetition. So I just added some of the aspects of the conscious sedation and everything. So we will, inshallah, tomorrow, or if I'm not able to do it tomorrow, day after tomorrow, we will continue with this topic. Okay. So any questions? do listen to the previous discussion if you want to understand the holy, and because some of the things were missing, I just try to cover because we couldn't do the endovascular part. Any questions, please? Yes, before I finish, I will just take a minute to have a small scenario. A patient, arteriopath, okay, patient with atherosclerosis disease had MI 1 week ago. Okay, so it is acute MI. This patient had angioplasty for 2 vessels, 2 stents, 2 drug-eluting stents were done, and patient is on dual antiplatelet. Okay, so now this patient is presented with severe limb pain. So they have found it to be limb ischemia. There is bluish. The surgeon want to, the vascular surgeon want to do the embolectomy. Okay. So what are embolectomy of, like they want to do this vascular bypass. Okay. Either femorofemoral or popliteal. So first of all, this is acute MI. So what sort of surgery it is? Anyone, please? Doctor? Yes, Dr. Homera. What sort of surgery it is?
Sir, high risk surgery.
It's a high risk surgery. Can you delay it?
No, sir.
Why? Patient
For the
will lose
preservation
limb.
of the limb.
Patient will lose the limb. If you delay it, there will be limb ischemia and patient will lose the limb, either in the form of sepsis, and patient might need and ending up having this amputation. Okay. So now if you want to proceed for it, you can discuss with the surgeon. This will be a high risk procedure. Patient might need, patient should be in ICU, of course. Patient will be in ICU, and they can do it with either endovascular. If they are doing endovascular, you can do it in local, and you just will be doing the monitored anesthesia care with all the gadgets and all the high risk preparation. And if they are doing in GA, for example, you have to do the stress response blunting. Okay. And then you have to do the invasive monitoring. Okay. And there are chances of what you call a perioperative, what do you say, perioperative increased cardiac mortality and morbidity. Okay. So can you do regional anesthesia in this patient?
No, sir. Mostly we avoid it.
Yes, because patient is on dual antiplatelet therapy. It will be a risky one, especially the deep blocks. For example, your central neuroaxial block will be definitely you cannot give it. Yes, femoral nerve block, you can think about under ultrasound, but you will do risk versus benefit. Okay, so there will be high risk of, so like this is it is like that. This is just a scenario which is related to the topic which we discuss. Okay, so inshallah tomorrow or day after tomorrow we will discuss the next topic. Okay, so thanks a lot. Inshallah we will meet. So you all are welcome to ask any questions anytime. Okay, so thank you very much.